All things are poison, and nothing is without poison. Only the dosage distinguishes the killer from the cure. If that sounds crazy to you, consider the case of blood thinner warfarin, now one of the most prescribed drugs in the world. Warfarin was originally marketed and is still commonly used as rat poison. The same substance that kills rodents protects the lives of millions of people. Killer or cure, the difference is in the dose. But it gets more complicated. A safe dose for one person might be dangerous, even lethal for another. So, how do doctors know how much of a medicine to prescribe? At first, they make an educated guess. Then, depending on how well the patient responds, they might adjust the dose. Unfortunately, for very sick patients, the delay caused by this trial and error process can be harmful or even life threatening. This is where pharmacogenomics comes into play. Have you ever taken a medicine that didn't work or that caused bad side effects? If so, you know that not everyone responds the same way to medications. What works for one person may not be as effective for others. One size does not fit all. A few years ago, a 2-week-old baby boy died from a morphine overdose. Doctors thought, how could this happen to a healthy baby who was not on any medications? Investigators discovered that the baby received morphine through the breast milk of his mother. She was taking codeine for pain after delivery. Codeine is found in Tylenol number 3, a painkiller prescribed to many new mothers to relieve postpartum pain. Yet the vast majority of these breastfeeding mothers have healthy babies. So, what happened in this case? You see, when a drug enters the body, it is metabolized by enzymes, and the most well known family of drug metabolizing enzymes are cytochrome P450 enzymes. Take, for example, CYP2D6, an enzyme responsible for processing about one fourth of all prescription drugs. Also, a person can be classified as ultra rapid, rapid, intermediate, and poor metabolizers based on what combination of CYP2D6 alleles they inherited. Majority of people are rapid metabolizers. In rare cases, a person can be an ultra rapid metabolizer. Now, codeine is a weak painkiller. It is a prodrug that needs to be activated into morphine by CYP2D6 to be an effective painkiller. Now, consider this. If all metabolizer types were given the same codeine dose, the ultra rapid metabolizer would convert way too much codeine into morphine. So, they should be receiving lower dose to prevent overdose. Now, back to our case. The mother turned out to be an ultra rapid metabolizer of codeine, so the excess morphine entered her breast milk and into her son, which caused an overdose. In the year 2007, that is a year after this incident, the FDA added a warning label on codeine use during breastfeeding, recommending the lowest dose to be used in nursing mothers. Later on in 2017, they strengthened the warning to not at all recommend codeine in nursing mothers. Now, the takeaway from this story: is codeine a bad drug? It depends on the person. It is great for rapid and normal metabolizers, whereas it is terrible for ultra rapid and poor metabolizers. Unfortunately, we just don't know who the right people are unless we do genetic testing, which is still quite expensive and has implications on privacy and ethical issues. But surely, this tragedy could have been avoided if doctors knew that the mother was an ultra rapid metabolizer, so she would not be prescribed codeine. Now, this story isn't just applicable to codeine and CYP2D6. Almost all drugs are metabolized by a combination of CYP450 and phase 2 enzymes. Genetic variations are a major cause of ADRs. Imagine if we can use pharmacogenomic information to prescribe each individual patient the most effective and least harmful medication based on their genetic makeup. Not only could it prevent a baby dying from toxic breast milk, it could also prevent bone marrow damage in a patient with autoimmune disease, reduce the risk of bleeding for people with bad hearts, and increase the chance a person is protected from future strokes, just to name a few. But this is easier said than done. The hardest barrier to using pharmacogenomic information in the clinic is relating genes to outcomes. While the example of codeine seems straightforward, most drugs have such a complex metabolic pathway involving multiple enzymes that it is difficult to predict the patient's response. Further complicating the situation are genetic changes in drug transporters and receptors, as well as non genetic reasons such as age, gender concurrent diseases, drug drug interactions, diet, and other environment interactions. All of these also influence a drug's effect on a person. The National Institute of General Medical Sciences created the Pharmacogenetics Research Network (PGRN) in 2000. The researchers expect that the knowledge they uncover will help doctors use genetic information to tailor treatments for each patient, thus making drugs safer and more effective for everyone. What role do genes play in how medicines work? Just like how our genes determine hair and eye color, they partly affect how our bodies respond to medicine. The word pharmacon means science of drugs, and genomics is the study of genes and their functions. Basically, pharmacogenomics is the study of how genes affect a person's response to the drug. There's still a lot of research going on about pharmacogenomics. Perhaps in the future, when more research is done and genetic testing becomes more routine, doctors can also use genetic information when prescribing medicine to maximize benefits and minimize harms for every patient. I believe pharmacogenomics is the key to unlocking medical potential hidden within our genes. The goal is to provide the right drug for the right patient at the right dose.